Well, great discussion so far. How many have seen a decrease in the number of RAC audits over the last 12 months? Probably nobody. The 2016 outpatient rule, which was effective for dates of service January 1st, is actually taking the Two-Midnight Rule reviews away from the recovery audit contractors because they were so aggressive. And they're going to be done primarily by the direct Medicare contractors. So we probably will see a significant decrease in them going forward, just to answer that specific question. How many utilize mid-levels currently in the staffing of their department? Anybody not. 0 mid-levels. There are a couple of groups, and there could be good reasons for that. Typically, it's a Democratic fee-for-service group that is deeply adherent to that physician culture, and they are able to recruit. There's no right answer for mid-levels. We'll go through some of the guiding principles, both compliance, as Sherry mentioned, both financial, reimbursement, and documentation. And then you'll have to decide what fits well for your group. Who can I recruit? Who fits well in our department? Who works well in a fast track that's non-contiguous and not really so directly supervised versus who fits well in the main ED? We'll cover all of those topics. Sherry, thank you for the lead-in. Their terminology has changed, so just so we all have the same lexicon of information, PA is physician assistant, NP, nurse practitioner, MLP, older term, mid-level provider. The next term is probably not one that folks in the audience use, but it's used in all the regulatory language. Non-physician practitioner, it's a Medicare term, and it combines PAs and NPs together. APP, advanced practice provider, that's the common one that's used now. APRN, advanced practice, and that's just speaking about registered nurses and includes actually midwives, clinical nurse specialists, and the CRNAs. And then you'll often hear folks talk about allied health professionals, and that's way too broad. Typically includes lots of folks like lab techs and medical assistants who would be involved in drawing blood. Let's see how we're doing. Okay. And then, so we have a complete set of reference information, training and licensure. Both NPs and PAs typically have a Bachelor of Science, graduate level education. And here's the big difference I have found in my own practice. Nurse practitioners start their lives as very, very successful and clinically oriented nurses with a patient-centric focus. How is this impacting the person in the bed? PAs go through things more like the physician culture, disease-centric. What is that disease? How do I fix it? And we need to adjust the way we relate and manage mid-level providers based on where they're coming from related to these two issues. One isn't necessarily better. As managers and leaders in our department, we need to figure out how to connect with these two different processes. In many states, NPs can actually work fully independently, and I did some research just before coming out here, and I found 250 practices solely operated by nurse practitioners, and that will grow. There is a primary care void. We talked about it. One of the gentlemen brought up, hey, there's this 8-year lag between when you pick your specialty and our need for providers. So if we hit the we need more primary care physician button right now, it will take 8 years to get there. And the federal government is going about it in a way that doesn't make much sense. Just putting on the reimbursement hat. In order to grow the primary care base, they are all the way at the end, after you've chosen your specialty, gone through training and been in practice and developed a large following of complex Medicare patients. There are now extra codes related to complex care management that the feds are using to funnel money to primary care providers. And they think that, I don't know, in 20 years, that'll trickle down to folks making medical school decisions because they'll see median salaries a little bit higher. So I think we will continue to have a void of primary care physicians, and we will continue to see it filled by NPs and PAs. Scope of practice. Essentially, the scope of practice is unlimited in most states. It's under the discretion and direction of the physician supervisor. And the PAs have a collaboration agreement. Everybody has one in place that's hiring PAs. They can order typical ED tests and studies. They can really typically do anything. Then that's at the state level. Then there's hospital level credentialing. How many have PAs intubating occasionally in their department? Intubating. Yeah, a lot of hands going up. Now, a lot of those PAs have EMT experience on the back end. But just to give a sense that it's very, very broad. And in my own shop, they are the proceduralists. They're not going to put in a very, very fast chest tube, but LP, central line, laceration repair, I&D, pilonidal cyst, whatever it is. And then state-specific, and I've got some resources so that folks can check their states. The thing that seems to vary is the number of PAs a physician can supervise and whether a co-signature is required. And maybe during the Q&A, we'll hear some issues related to medical legal issues within the context of a 30-minute lecture. I couldn't cover all of them. Nurse practitioners, fully independent practice in a lot of states. And then there are a couple of states that are very, very slow to adopt or to real national standards. California, Texas, and Florida, if you're in those 3 states, just be aware. And I've got right at the end state-specific resources related to scope of practice for both the NPs and PAs. All right, so let's get into the meat of it, the billing issues. NPs and PAs are recognized by Medicare to bill. Everyone that raised their hand that says, I'm working with NPs, I'm working with PAs, they should be credentialed with Medicare. They should be credentialed with Medicare. It surprises me when occasionally we begin new work with a group and they have this cadre of physician assistants and they were never credentialed with Medicare. That doesn't mean that everything gets billed out under the PA. We'll talk about the pros and cons and the processes related to documentation. And then again, Medicare uses this term NPP, non-physician practitioner. If the PA performs a service, it is paid at 85% of the physician fee schedule. So if Medicare, for instance, 99283 would pay $62.70, that's real accurate information for 2016. If the PA provides the service, $53.30. And more accurately, if the service is billed out under the PA's NPI number, National Provider Identifier number, you get a 15% haircut. Not that big a difference at level 3. How about a laceration repair? I already mentioned, hey, the PAs in my own shop are procedureless. Laceration, simple laceration, CPT code 12001, $45.47, reduced to $38.65. Very small haircut there. Here's the only area, and we sort of all joked about this yesterday. The giant RVU orthopedic procedures, maybe at this point it starts to at least make sense to have an awareness that 15% discount going from $292 to $248, a loss of about $45. Maybe it makes sense. Now, when can we bill under the physician? If there is, quote, a shared service. I'm going to go a little bit slowly here for the sentinel point. The shared service concept with the PAs only applies to 99281 through 99285. It does not apply to procedures. It does not apply to critical care. The PAs we already established can do anything. That doesn't mean that it will always be billed out under us as the attending physicians at the bedside. It only applies to evaluation and management services, which in the ED would be 99281 through 99285. And then there are some requirements. By meeting those requirements, you are getting rid of the 15% haircut. And I see a couple of uncertain faces. I'll share the primary source documents. They've been out since 2002. And if you're uncertain if you're on the right track and you want to have a little sidebar conversation, that's fine. That wouldn't be the first time it's happened. E&M is shared between a physician and an NPP from the same group practice. A face-to-face portion of the service may be billed using either the physician or the NPP's NPI number. Of course, we would pick the physician's NPI number because we would then receive 100% of the fee schedule, $62 instead of the $49. Payment will be made at the appropriate physician's fee schedule based on the UPIN that's on the claim. That's Medicare Transmittal 1776. It's pretty general language. It's available on the ACIP website. You can literally Google Medicare Transmittal 1776, and I've got the hot link in the resources page for this talk. Medicare also publishes on an annual basis their claims processing manual, and this is right out of publication 100-04, chapter 12. It's the current year. A shared visit when the physician and MPP each personally perform a substantive portion. Whoa, in our regulatory world, when they throw out these descriptive terms with sort of the presses stop and we all debate, what is substantive? And only the government could come up with some substantive. How many in this room think substantive would mean more than 50%? Like just based on English, it would be more than, well, in fact, it's not. It's all or some portion of the history exam or medical decision-making with a lot of ors in there. So a little bit of an attestation and then some case-specific information that shows a face-to-face interaction related to the history or the physical exam or the medical decision-making. And for those who sort of were a little cross-eyed about, hey, this concept doesn't apply to procedures in critical care, here's a citation right out of the Medicare Claims Processing Manual. The split shared EM policy does not apply to critical care services or procedures. So those are either billed out under the PA, or they're simply performed by the doctor. Simply performed by the doctor. So if the PA performs a laceration repair on a Medicare patient, it's billed out under the PA. If the PA delivers critical care services to a Medicare patient, it's billed out under the PA. If they see an asthma patient, a COPD patient, that's a Medicare patient, 99284, we write our attestation note with a little bit of that satisfying substantive portion, and we'll look at some examples here. And I really slowed down purposely here to dissect this. History, or exam, or medical decision making. So in the end, the practical solution is, if you're using an attestation, add some face-to-face information. This has been audited a ton. And I'll show examples of what wins under audit and what loses under audit. I see a lot of hot people in the first few rows. There's some fanning going on, so I'll just mention that. Shared visit example. Medicare. This is one of the largest Medicare carriers, CGS. I love it when they publish an example, because then we can take that all the way to the administrative law judge level and say, hey, this is what you guys published. We're just trying to adhere to it. I have personally performed a face-to-face diagnostic evaluation on this patient. I have reviewed and agreed with the care plan. That all sounds easy, and that might just be a checkbox or a macro. But then we're going to add this portion. History and exam by me shows abdomen was tender to touch, no rebound, labs and CT scan are negative. I am Toradol given for pain, patient discharged home, and signed by me as the treating physician. Not written by and signed by the PA on my behalf, signed by me as the treating physician. And then they did us the favor of publishing things that they didn't like. These are easy. Seen and examined, didn't agree with plan. All the ways that as a resident and a medical student, my attendings documented apparently were not really okay. And then this one is a really good example. I have personally seen and examined the patient independently. I reviewed the PA's history and MDM and agree with the assessment of plan as written, signed by the physician. That is an example published by Medicare that is not acceptable. What are we missing? That substantive portion of case-specific information. So let's get down to the real world. Here are some examples. These are real charts. They were under audit. They did not pass. Conversation with attending. I reviewed the plan with the patient. Am I attending accordingly? We outlined the plan of care together and discussed pros and cons, signed by the PA. Not good. I've seen and evaluated the patient. I reviewed the MLP's documentation, agree with the findings of the plan of care. No substantive note. So what's good stuff? This patient has been seen and evaluated by myself, the nurse practitioner, and sort of stepping out of the billing character, what are we looking for? We're really looking for quality of care. Not just how do we wiggle through the billing process to not receive the 15% haircut. We're looking for an actual patient-level interaction that at the attending level matters. And I think we all recognize that over time, PAs can see ankle sprains just fine. But sometimes limb pain is new onset AFib with an embolism, or it's a DVT. And sometimes vague weakness shouldn't go to fast track. We're looking to really show value in the chart. This patient has been seen and evaluated by myself and the nurse practitioners. I was directly involved. Pertinent exam findings include a non-focal neuro exam. I was face-to-face. I saw and touched the patient. CAT scan of the patient's head was concerning for a subdural. Does take Pradaxa. Referred to trauma surgery for admission. Nice example that went through audit, no problem. Here's a minimalist note that actually went through audit, no problem. Course of care, seen and examined, agree with above, positive shortness of breath, exam decreased breath sounds bilaterally, normal chest x-ray, sent in for admission for a COPD exacerbation. I would recommend starting with an attestation that's consistent with a published Medicare CGS language, and then adding some case-specific information. And I think that makes sense. And it's not just for billing purposes, it's in particular for those higher level cases showing real attending involvement in the case. Now let's talk about the reimbursement. Medicare Transmittal 1776, 100% if that 99281 through 99285 is billed out under the attending's NPI number, and only 85% if under the PA. And again, PA procedures typically billed out under the PA. And we're really referencing Medicare and carriers that follow Medicare, and we'll get to that next. What can the PAs do? What can the NPs do, and what can they bill for? And there are really some myths that we'll go through. Scope of practice varies by state, but it's generally, I looked at most states. AAPA.org, great reference. They have direct links to the individual state websites. under the direction of the supervising physician. 2/3 of the hands went up related to intubation, just as a good check. Prescription writing narcotics procedures, most states allow determination by the supervising doc. And then I occasionally see insurance companies push back against two things: critical care and fracture care. Critical care because it's a critical care service, and fracture care because deep in the Excel files that are maintained by the payers, the fracture care that we submit looks to them like a major surgery because it's got what's called a 90-day global period. Almost always won on appeal because you just use the state scope of practice and show supervision. So I would appeal those if you're getting pushback. And then what about critical care? Can PAs and NPs really provide critical care? Now we've got a terrific primary source reference. This is published by Medicare, one of their MedLearn Matters. Transmittal 5993. NPPs may provide critical care services and report the payment under their NPI number when these services meet the critical care services definition. Don't forget, it has to be within the scope of practice. It's within the scope of practice in almost all 50 states. Meet the collaboration agreement. So you need to have your collaboration agreement in place, which we all do. You cannot report a split-shared EM service performed by a physician and a qualified MPP of the same group for a critical care service. And the down in the weeds reason is because it's a time service. So you can't have the PA provide 15 minutes of time, and then you provide 16 minutes of time, and now we've got 31 minutes of time. So it's just for 99281 through 99285, using the examples that I showed. So where should they work? How many have the PAs working mostly in fast track, seeing lower acuity patients? Probably half the answer. How many have really fully integrated PAs into the main ED? It's kind of a similar number of hands. And going back to the original statements that I made at the beginning of the talk, there's no one size fits all. How am I doing with physician recruiting? How high is the acuity in my department? What is my group culture, which all of us will engage in trying to influence? And what type of patients and acuity are we seeing? Main ED. The PAs are happy in the main ED because they feel like they're really on the path to intellectual growth and seeing new patients. Attract and retain the best and brightest. They generally have very high satisfaction, longer retention. Sometimes there's some medical staff pushback, but most of the medical staff that are the grumbly old orthopedists are all using PAs and NPs in their own practice at this point. That's an easy hold up the mirror moment to them, said nicely. And then if there is a culture within our own ED group, and for those 3 or 4 groups that are exclusively physician-led, that's a different process. That's a whole separate conversation. But if you're already using PAs, everybody needs to get on board. It's not enough anymore for any of us on an individual basis to be a doc treating a patient in room 3. We are running complicated departments as a team, and the PAs and NPs are part of that team. Fast track, very high efficiency. We'll actually look at some sample data. Their training suited absolutely to acuity. Most of the procedures are in fast track, but they really run victim to an assembly line mentality. And for a lot of groups, it's a little bit of, and I'll show some data, they're much more efficient in the fast track. It's more in line with their culture and training. And from a risk management perspective, particularly if you're a little tight in the way you set up your fast track triage processes, I think you're performing some risk mitigation. But that assembly line mentality leads to burnout. And then how many have a mid-level at triage? Couple hands. How many have a mid-level at triage and they have less than 40,000 visits? So it would be a great discussion to have. It works well at about 60,000 visits. At 30, 35,000 visits, what you're doing with that mid-level is making up for an inadequate triage process, typically. Because unless your acuity is very low, there are not enough treat and treat patients. Or unless you have what Jim said as a results and waiting area where the PA can really actually start the care, you're really just taking a bottleneck area and trying to put a provider in front of it. So separate conversation. This is real data. It's meant to be sample and illustrative, not benchmark data. In order to have real benchmark data, and I really agree with Jim Augustine's overall premise, you need to stratify out based on volume and acuity. I looked at our 250 sites. I picked 15 relatively at random. Some are community, some are academic, some are rural, some are big. Looking at PA patients per hour in the main ED. And the median is about 1.3. How many have the PAs in the main ED approaching 1.8 to 2.0 patients an hour? So I have one very productive department back there in the middle. Otherwise, it seems uncommon. How many have the PAs in the main ED at 1.0 or less? So I think I got one gentleman 2 rows back with a problem. Okay, we'll have to work on that. So 1.3, that passes the sniff test in the whole room here, and it's consistent with the sort of random sample across 15 sites. Now let's look at the RVUs per hour in the main ED. So I showed the equation yesterday, first lecture, first slide, RVUs per patient times patients per hour. Now efficiency matters. Efficiency, particularly for a PA in the main ED, it's not that they're not documenting well, they're documenting fine. They typically document just as well as any of the physicians. We're stretching the clinical thought process, so appropriately they're slowing down. Total RVUs per hour main ED, the median's about 5 in this sample, and I think that passes the sniff test as well. So we're generating 5 RVUs an hour in the main ED. Now let's put a PA in fast track where it's more consistent with that disease-centric lower acuity training, and the mean for patients per hour across this random illustrative sample, about 2.8. How many have their PA seeing 3.5 to 4.0 patients an hour in the fast track? No hands. How many have their PA seeing 2.5 or less patients in the fast track? That same group. We're going to have to talk a little bit more. 2.8 was a median here, and I think somewhere between 2.5 and 3.0 probably represents about 75% of the folks in this room. Now let's look at the RVUs. Instead of 5 RVUs, we're at 6.6 RVUs as the median. 1.6 out of 5, about a 30% increase in RVU generation efficiency. Now you can say, well, a physician would be faster in fast track also. And they would, and that's, I think, part of the reason why there's not a one-size-fits-all process. But this data is simply demonstrating that the PAs are suited to the fast track process. That then needs to be balanced with, can I recruit doctors? Can I recruit PAs? And of the PAs that I do recruit, will they be happy with me and my group long-term in fast track? Or will they develop that burnout assembly line mentality? And do we need to have 20% of the shifts rotating into the main ED where we can really attain and attract the best and brightest? Let's look at the finances with some real numbers here. 18 patients need to be seen. Physicians are faster. They're not 1.3, they're closer to 1.8. 1.8 patients per hour requires 10 hours of coverage. I picked a random sample cost out of the Daniel Stern survey, $170 an hour. So it's going to cost me $1,700 to staff and see my 18 patients, $94 per patient. Now the PA is slower. They're only at 1.3 patients per hour. Our random illustrative sample showed. And so I need more coverage, 13.8 hours of coverage. And again, I've got a salary report in the resources page for the physician assistants, $70 an hour, $966. So they cost a lot less. In fact, $53.67 per patient compared to $94, a 45% decrease in cost. The PAs are a little bit slower, but they are very efficient and very economically efficient in fast track. But that can't exist in isolation. We need appropriate fast track and low acuity presentation protocols, and we need collaboration because every once in a while, every single person in this room could give a story in the last month of the patient that was triaged as X and actually had a subdural, had a DVT, had a PE, common ED presentation. So again, these are the economics, but what needs to layer on top is effective group oversight of the process. Now let's not forget, if these were Medicare patients, you'd apply a 15% discount. But this is about a 45% efficiency, and that 15% discount at the very high levels is $26. We've got a $45 difference here. And at the lower levels, it's only $9.45. And Medicare patients typically aren't lower acuity, typically aren't presenting with complaints that move them to the fast track area. But I think in order to be honest with the numbers, some of those patients will have a 15% discount applied. And again, many groups have physicians see higher acuity patients. In my own shop, non-contiguous fast track, it's just a reflection of our sort of stepwise growth. It's kind of far away. It's down the hall. There's a very open culture. but there's not a lot of physician physical presence in that area. Extremes of age don't go to fast track. So if you're over 60, if you're under 2 years of age, I don't care what you have. We're going to just put you in the main ED because there's just not a whole lot of physician presence in that fast track. Staffing considerations. This was actually a real process. I don't know how many have seen a local urgent care actually close. I only really see them growing. But this happened on the West Coast. It was about 6 months ago. Single coverage ED, local urgent care closes. Large increase in volume, about 18 patients a day for this community hospital. PA coverage, 1.5 patients per hour. At 12 hours of cost, it costs you $840 a day to cover those low acuity patients. Physician coverage, 2.5 patients an hour. Low acuity patients, physicians are faster. At 7 hours of doc coverage, $1,190 per day. So the PAs are more efficient at seeing low acuity patients and they cost less, even given the small number of Medicare patients. But again, there needs to be collaboration and oversight. Triage is far from a perfect science at this point. Requirements for a successful PA program absolutely need group buy-in. So for the 4 folks that raise their hand that are thinking, well, gee, we have a 20% admit rate. We're seeing 100 patients a day. That means there are 80 patients that aren't admitted. Maybe half of those could be seen in fast track. Those are probably real numbers. 40 patients a day, that sounds like a good 12-hour PA shift. The first thing to start with is here, group buy-in. Because the PAs have to be part of a relationship. They have to be part of a relationship. Approachable, collaborative environment, and there's a couple of things that create that. Mentorship program for new grads. If you're going to hire new grads, it's very different than hiring a new attending. There really needs to be a paired up and orientation process. And these are the 2 things that I've seen create the most success. A chief PA that is the liaison, because now we're talking about, particularly if you're going to start a program or hire a bunch of new grads, you've got a 26-year-old physician assistant who just finished their training, is very gung-ho, and a bunch of 50-year-old seasoned night physicians that they're trying to interact with. There needs to be a process by which you can't have that direct interaction right away. That takes a couple of years for that relationship to grow. Chief PA. And on the other side, a physician designee and champion. And it can't be the doctor of last resort. We found in my own group, it was a lot of work, and we took turns every 2 years, being the the physician designee. I did it twice. It's a lot of work. It's a lot of managing people, and managing PAs is very different than managing doctors. Do PAs care a lot about benefits, retirement plan contributions? They care a lot about hourly salary, typically. It's a very different process. And then invest in their professionalism. Absolutely. If you are going to expand a PA program based on some of the finances that we looked at, it's not just that assembly line mentality. You want to grow valued members of your organization. And in addition to mentorship and a chief PA and a designated physician, we really have pretty robust CME for them. And I think that works very well. A couple of conclusions. PAs and NPs, growing component of the ED workforce. We've found that a blend of fast track and main ED is common, and that creates both the economic efficiency and that collaborative and growth experience that the best and brightest PAs are looking for. Now, your own staffing model has to be based on a combination of recruiting options, economic efficiency, retention factors, and your own patient processes as well. I've got a couple of nice resources here. PA scope of practice by state, NP scope of practice by state. ACEP has some nice resources, reimbursement FAQ. Here is the actual link to Transmittal 1776 and a PA salary report. And again, my contact information is here. I receive inbound email questions from folks all the time. Just give me a little context. Thank you.